Thank you very much for your very kind introduction. Sawadee, this is how we greet in Thailand. So it's my honor to be here in the very big conference and amazing city of New Delhi. So my task today is to talk about comprehensive approach to stroke in young adults. So what I will be covering is that briefly about epidemiology, and then about the subtypes of stroke in young adults and how to approach them, and just want to share with you some interesting cases. Regarding the epidemiology of stroke in young adults, this is the breakdowns of the age of young adults. Normally, we would say people who are younger than 50 or 45 would be young adults in terms of stroke. So you can see the majority of them are in the left side, meaning that they are kind of older young people. Fewer stroke cases are in very, very young people. So this is data from Thailand, and we got it from the Ministry of Public Health, and it shows the distribution of the age of stroke in young adults. Again, just want to emphasize to you that stroke in young adults comprises of around 11% of all stroke. Not many of them, but they are there. So the number is actually increasing in this data, showing the data from 1989 in some countries and in 99 some countries, and comparing to the more recent ones. Oh, okay, thank you. The more recent ones. So you can see that, especially in the Black American, the incidence of stroke in the young adults increased dramatically, and it's the same for every other countries, but in the different proportion. So we have more and more stroke in younger adults. So what about the subtypes of stroke in young adults? As you can see here, most of the young adults cases with stroke are still ischemic, but the percentage of hemorrhagic and subarachnoid hemorrhage are increasing, even higher than the older ones. So there are some discrepancy, but the majority are still ischemic stroke. For the hemorrhagic stroke in the young, as I said, higher proportion in comparing to the older ones. The etiology can be diverse. Most of the time, it's related to hypertension still. But the cause like AVM or cavernous angioma or other unusual diseases are rising. I'm not going to be focusing on hemorrhagic stroke today. I'll be focusing more on ischemic stroke. So when you look at ischemic stroke in the young, kind of categorize them into different categories. And you can see that in the young, very young ones on the left side, and like older ones, older young on the right side. Cryptogenic seems to be the majority of the cases in younger ones, and there are some increasing small vessel disease and some kind of atherosclerosis in the older ones. So meaning that they might have some risk factors, just like the older patients. And for the kind of orange one here, you can see that there are more other undetermined or other causes of stroke in the younger ones. So there are some unusual causes that I'm going to show to you today. So how do we approach patients who are young strokes? These are the causes of ischemic stroke in elderly and also in the young. It can be categorized as first the disease of the blood vessel, right? The blood vessel is not good. Maybe the atherosclerosis. Maybe they have some vasculitis. Maybe they have some other causes like non-atherosclerotic type of non-vasculitic stroke. So this would include dissection, moya, and vasospasm. The second cause would be the cardioembolic or other embolic, not restricted to cardiac. So we can have valvular heart disease, we can have arrhythmia, like in the older adults, we can have other cardiac disease. PFO is one of the causes of stroke in young adults, cardiomyopathy or post-MI. The third one would be small vessel disease, which can be related to some genetics diseases and also some other uncommon causes. And the last one would be the coagulopathy or blood component problem. They can have high platelets, high red cells, or abnormal in coagulation causing stroke. So this is how to approach, this is the initial evaluation in young adults recommended here in this paper. So thorough history, I think, is very important. And then do physical exam. And then we need to do brain imaging and also vascular imaging to see how the vessel looks like. And then in some cases, we would need the cardiac evaluation, thoracic or transesophageal echo, and rhythm monitoring. And then laboratory workup. In some cases, when you think about vasculitis, you may want to do some inflammatory markers. So to me, these are some list that you may think about. But again, you have to go back to the history of the physical exam to determine what you're going to do for the patient. So I think it's more like individualized. You can just apply all the things to each patient, to all patients. So it's individualized according to the history physical exam and the initial workup. So for example, you have a 45-year-old patient with uncontrolled diabetes, hypertension, and smoke for 25 years. And then he presented with large vessel stenosis, maybe carotid or intracranial. It's very likely that this patient is having atherosclerosis. You probably don't need to do TEE or do the sophisticated lab for this case. It's pretty straightforward, although he's 45. Another case, a 30-year-old patient, sudden right-sided weakness with global aphasia. It's very clear that it's an MCA stroke, right? Very sudden onset, so it's likely to be emboli. So you have to work up more in the cardiac side of the problem. Another patient, like 40-year-old, with recurrent stroke in different territories within 2 months. So this is very aggressive, having multiple stroke in only 2 months. So you're thinking of maybe more aggressive disease like vasculitis or multiple emboli from the heart or some other coagulopathy problem that causes multiple stroke in a very short period of time. Or this patient, 20-year-old male, history of motorcycle accident 2 weeks ago, and then having a stroke in the carotid territory. So you have to think about dissection. So it's pretty clear that it might be the cause of the stroke in this patient. So I think it's more individualized according to the history and physical exam. So I'm going to just share with you some interesting cases that I think history and physical exam helps, and also investigation would help with the final diagnosis. So as I mentioned, causes of stroke in the young are like categorized like this. So for the large vessel disease, this is an example. Here, we have to look at the history and physical exam. We might want to think that this is more like athero if they have strong history of atherosclerosis. Some minor injury can cause dissection, not only a frank motorcycle accident. Moya, in some cases, they might present with some trouble in children. They cry and they got a transient ischemic attack. In patients with vasospasm, they might have history of taking some medication or some drugs or a thunderclap headache that precedes the neurological deficits. So for some vasculitis, you might have some history of autoimmune disease or like drug use, or I have a case with herpes zoster ophthalmic branch and then develop stroke later on. So you have to look for this kind of history. For investigation, of course, vascular imaging would be important for patients who is suspected to have vasculopathy. So this is an example of a male patient, 43-year-old, had recurrent left hemiparesis and dysgeusia, meaning that he tastes the ice cream and he feels that the ice cream is bitter instead of sweet. So the taste is different. So also has complained of right-sided headache for a week. And the episodes of the left hemiparesis lasted about 5 to 10 minutes. So physical exam was normal because he returned back to normal. So it turned out that he has dissection. You did the investigation and found that the carotid is narrow and there's a clot in the wall of the carotid artery. But when you ask for the history, he said he's a gardener. He does gardening all the time. And when you really ask how he did the gardening, when you get the answer, he does this, and it may injure his carotid artery, and that causes his carotid dissection. If you don't go dig down into history, you might not know the real cause of the illness. Another case, a female patient presented with left leg weakness, just one-sided left leg, the leg weakness. So she has ACA stroke, as you can see from the diffusion imaging. The history is like 10 days ago, she kind of went to swim in a very cold pool. And then she developed sudden severe headache, like thunderclap headache. And then the headache recurred a couple of times, and then she developed the weakness. So you may think of this lady having some kind of vascular disease, and it turns out that she's having reversible vasoconstriction syndrome, maybe related to cold weather or cold water. And we did a scan, and it looks like this, and then we monitor, gave her nimodipine, and her blood vessel recovered completely. Otherwise, we will be thinking about vasculitis or atherosclerosis, and the treatment will be different. And this is another case of vasoconstriction, and you can see that cortical subarachnoid hemorrhage is one of the keys, and some narrowing of the blood vessel in the brain. And this can be misdiagnosed as vasculitis as well. So another case of moya moya, a child coming with progressive stroke and history of crying and having a TIA. And you can see that collateral in moya moya disease. Some of the causes like cardiac cause in the young. So usually cardiac cause would cause sudden onset of neurological deficit. They may have normal vascular imaging, and you may want to look at the cardiac exam. This is a case of a female who presented with right arm weakness, and you see that the vessels are okay, just stroke in the cortical region, very sudden history. Turns out that she has PFO. After we did the bubble study on the cardiac echocardiogram, we found that she has a shunt in the heart. Another case of small vessel disease. You have to make sure that it's really small vessel in deep inside the brain, not cortical type of infarct. And this is a guy who is 45 years old, presented with multiple stroke and strong family history of stroke. And this is a case of Cadazel, familial type of stroke, small vessel. And this guy's mother has this type of finding in the imaging as well. So, and lastly, about the coagulopathy, you have to look for a history of coagulopathy, and this is a patient with high platelets and having a stroke. CBC is one of the routine exam lab that you would need. And this is another interesting lady, 39, presented with right hemiparesis and aphasia. And then we thought she had left MCA stroke, and then some history of dyspepsia. So we did thrombectomy in this case. So the operation went well. She was okay. And then 2 days later, this is thrombectomy. 2 days later, she developed more and more strokes just within a couple of days. So finally, we found that she had merantic endocarditis and hypercoagulopathy, and this is becoming more and more common in our population, not even the older ones, but younger ones. And this is CA pancreas. So just mention the last slide about other causes that may not be that even common. Migraine-related stroke can be part of stroke in the young, and you have to carefully ask for the history of migraine in these cases as well. So in conclusion, I share with you the stroke in the young adults, the epidemiology, the subtypes, the approach, and also I think the most important part is to take history physical exam and do the initial test and then work up after that. Thank you very much.
Thank you, Dr. Suwanwela. That was a very, you covered a lot in a short amount of time, and thank you for sticking to the time. We'll just have a couple of questions, and then we'll go to the next speaker, because there's many topics, and there's not enough time. If there are no questions, thank you.
There's one.
Sorry. Yes, please.
Sir, in the last winter, in January or February, I was having a 29 to 30 years old male, and it was ischemic stroke, mainly involving temporal lobe, and he was having seizures also. weakness improved or little bit difficulty in speaking is motor dysphasia, little bit. And the whole, I have investigated in detail the whole possible etiology I have searched for. The only abnormality I have got that high homocysteine level. So I just asked, I just want to ask whether to continue antiplatelets for the whole life or no. Folic acid I have given.
Thank you. I think it's kind of cortical stroke as far as I
Yeah.
kind of remember. So you had a patient with a cortical sign as well, right? Aphasia. So it's cortical. So if it's a stroke, it's going to be a large vessel, right? And you
Yeah, it
found
was
that.
large vessel.
Yeah. Okay. And the vascular exam was normal.
Yeah. I have investigated him in detail. There was no vasculitis. Autoimmune profile was normal.
And no stenosis of the
That
vessel, right?
angiography was also normal. Only abnormality I have got high homocysteine level. I have given him folic acid. Whether to give antiplatelets for the whole life or no. He is 29.
Yeah, high homocysteine usually relates with atherosclerosis or vessel stenosis. If you don't find the vessel stenosis, I don't think it's directly related. Anyway, if you don't find the cause, I think you should give antiplatelet for life for this patient. Another thing is to consider some other stroke mimics. You said the case is having cortical signs and also seizure. Maybe you may.
Seizure was there.
Yeah, you may want to think about mitochondrial disease as well.
Okay.
Like MELAS can present with stroke and seizure and cortical involvement. And if you follow the scan, it kind of resolves completely. It's going to be more like MELAS.
I have just recently have done
Thank
the
you. I think
MRI.
there's not enough time. We'll continue. You can have the discussion with the speaker.